We're here with Dr. Metz in the operating room. We're actually going to talk to him about his expertise in weight loss surgery. Before we talk about that, let's go through the history of weight loss surgery so people understand where we've come from and where we are now.
So it's great to be here in the operating room with you, Dr. Martin, and just looking at this operating table and thinking about the changes that have occurred in surgery just even since we were residents are profound.
Yeah.
But weight loss surgery really started in the United States in the 1960s, and the evolution that it's gone through has been profound, from big open incisions with massive OVAR tables and these chain retractors that we used to use to hold the ribs up, to these tiny little incisions that we use now, or even going through the mouth where there are no incisions whatsoever.
Right.
So it's pretty wild, the change in technology and the improvements in safety and quality and standardization that have occurred over the years.
Well, you know, in my research, they were talking about the beginning in the 60s with Mason and Ito. He was in Iowa. He was doing some stomach cancer surgeries, and they noticed that after the surgeries, the gastrectomies or partial gastrectomies, taking out part of the stomach, that they saw that the patients lost weight.
That's right.
And what did that lead to ultimately? Was that the Roux-en-Y or the gastric bypass ultimately?
That was the gastric bypass, that's right. So, and while I'm not the best in my medical historian expertise, we've seen a lot of evolution of that procedure because patients tended to do so well. But again, it was done open through a big incision, and the patients that it was used on in the 70s and 80s, and even into the 1990s, had a very high complication rate with big hernia rates in their large incisions. There was a 40% wound complication rate just from making such a big incision in people that had such thick fat tissue. Cutting through that, it's poorly oxygenated. They would get infections and leaks and hernias, and those things, while not completely eliminated, have gone, for the most part, away.
When did that change? When did you see the change in open surgeries to laparoscopic surgeries, specifically for gastric bypass, and now what you do with the duodenal switch? When did that change occur?
So the big changes occurred really for laparoscopy in the 1990s is when it started. People started doing laparoscopic Roux-en-Y gastric bypasses. So that same procedure that Ed Mason was doing open, we honed it and started doing it laparoscopically in the 90s, late 90s, but there were only a handful of people that were able to do that. In the 2000s, fellowships started popping up where people were getting advanced specialized training in these procedures laparoscopically. And now, in 2017, we're seeing even some of the Mount Everest of bariatric procedures, like the duodenal switch, being done laparoscopically. I do a laparoscopic loop duodenal switch in about an hour and 25 minutes.
It's amazing. Because I remember in training, you know, just the laparoscopic Roux-en-Ys or gastric bypass taking us 4 to 5 hours.
Right, and now
you're doing the more complicated procedure in an hour and a half.
Yeah.
Explain kind of in detail exactly what the gastric bypass is, also the duodenal switch and the vertical sleeve.
Sure. So I like to start with the sleeve because it's the sort of the least invasive of the three and the most natural of the three, and frankly the most popular of the three. So the sleeve gastrectomy, or vertical sleeve gastrectomy, is a laparoscopic procedure. I usually do it with 4 very small incisions. The biggest incision is about 12 millimeters. And I'm taking the stomach, which is about 1.5 liters. So you think about a 2-liter bottle of soda, 3/4 of that is 1.5 liters.
Yeah.
So I'm taking about 30% of that away, leaving patients with a little hot dog or banana-shaped stomach.
And that's from, you think about, you got your esophagus, you got the stomach, and then you got the duodenum. In the sleeve, you're keeping the esophagus, that junction that goes into the stomach, and also that goes into the duodenum.
That's right.
In the old ways, they used to cut straight across the stomach, but now you keep that sleeve going all the way down, and that's where you get the hot dog or banana.
That's exactly
comparison.
right.
Yeah.
And it's a tailoring term. People ask me, are you putting a sleeve on my stomach? But we're actually not. There's nothing that we're putting over the stomach. We're actually, it's a tailoring term. So just like taking the excess of the sleeve off on a jacket when you're making a jacket or a shirt, it's the same thing that we're doing.
And you said today, actually, you guys actually take that portion of the stomach that you staple off, you take that out. It
Yes.
doesn't stay
Yes.
in. Okay.
So we used to leave that in, and there was a procedure in the 1980s and 90s called the vertical banded gastroplasty, and they used to leave that section of stomach in, and in almost all the patients it grew back together, and then patients started gaining weight. So we specifically take that part out to prevent that from
A
happening.
majority of the patients, they do the sleeve, or at least some of the younger ones that don't have as much of the comorbid conditions or other problems like diabetes and hypertension or high blood pressure. But then some patients are actually excellent candidates for the gastric bypass.
That's
Explain
right.
that. Yeah.
That's right. So I like the gastric bypass for patients that are struggling with acid reflux because you're cutting across the vagus nerves, which are the nerves that cause acid to be produced in the stomach. And by cutting across that section, it reduces the acid burden, but it also makes the stomach so small and low pressure that if somebody lies down flat, they're not going to get the same bathing of their esophagus with acid like they had for the years prior to the procedure. Now, the gastric bypass is also a great option for people that are struggling with diabetes, but for people that are truly battling diabetes and have had diabetes for greater than 8 years or are on multiple injectable medications for diabetes like insulin, Levemir, some of the other advanced injectables, those patients don't lose their diabetes as readily as folks that have a duodenal switch. So a duodenal switch would be more powerful for getting rid of diabetes than any of the other procedures.
In terms of all those other problems, you go from the sleeve to the gastric bypass to the duodenal switch, and you're kind of getting an increasing effect on these other issues.
That's right.
What about weight loss?
Same thing.
Same thing. So the sleeve is a little less, the gastric bypass is a little bit more, and the duodenal switch is the most.
That's correct.
With the duodenal switch, what percentage are we talking about here?
So duodenal switch, most patients lose between 70 and 90% of their excess weight. The gastric bypass, the national statistics are usually 60 to 85% of their excess weight. And with the sleeve, it's 50 to 65% of their excess weight.
Let's talk about the duodenal switch. So that seems to be the most difficult surgery, and not surprisingly, that's one of your expertise, and that's what you do on a regular basis.
It is.
You're a center of excellence. You're involved in national studies related to this procedure. Let's get more in depth about the duodenal switch. We've explained at the beginning about the sleeve. Okay, so we take off of that portion of that stomach coming from the esophagus down to the duodenum, which is the first part of the small intestine. What is the second part of that procedure that gets you to the duodenal switch?
So the second part of the procedure is exactly what you're talking about. So we actually dissect the duodenum off of the head of the pancreas, which sounds horribly dangerous,
Right.
but if you are familiar with the anatomy and you've spent time in that neighborhood, it's something that's very straightforward. But for most surgeons, we don't spend a lot of time in that area. So I did a lot of specialized training to make sure that I was doing it safely prior to undertaking it on my own patients. And I dissect the duodenum off the head of the pancreas, and then I divide it just downstream from the valve that's at the bottom of the stomach, the pyloric valve.
Right.
Once you divide across that duodenum, I hook the ileum, which is the downstream portion of the small intestine, up to that duodenum. And I make sure that I am a few centimeters downstream from the valve that's at the bottom of the stomach, the pyloric valve, so the patients get the added effect of staying full longer and the contents of the intestine don't reflux back
into the
up
stomach.
into the stomach. That's
In the
right.
stomach. And then, so when you talk about connecting it to the ileum, how far upstream from the cecum are you connecting it?
So I actually go to the cecum, or the first part of the colon,
The large
or the
valve.
large intestine,
Yeah.
and I run the bowel backwards 300 centimeters,
Okay.
which is about 6 feet.
Because in the early parts of those surgeries, this duodenal switch, or what was before that, they were doing like 50
That's
centimeters.
exactly right.
Like really close to that cecum, and
Yeah.
they started to have problems with
Terrible problems, chronic diarrhea, liver failure, all sorts of very bad protein calorie malnutrition and vitamin insufficiencies. And really, as I touched on earlier, the most horrible problem was just chronic diarrhea that these folks were getting.
that. And so moving it back up kind of solves a lot of those
It
problems.
does. It does. And I have yet to have to reverse any of these procedures just because we're making a much more conservative bypass. But we're still seeing the same resolution of diabetes and resolution of the other medical problems.
I think it's one thing to understand with, specifically with this surgery, it's so technical that a lot of places don't even offer it. If you go and look around, do your research for bariatric surgeons, you're going to see that they don't often offer it even open. Like Dr. Metz does it laparoscopically, so that's through the small incisions with little tubes. They don't even offer it with the larger incisions. And what you'll see is they'll do it in 2 stages to make it a little bit safer for them and the surgeon. So this is really where we're going now with bariatric surgery. Dr. Metz is kind of ahead of the curve. He's pushing out in front, and there's other places like that in the United States.
There are.
You guys are coming out with a study pretty soon.
We are. We're one of 6 centers in the country that's been doing a long-term study on the loop duodenal switch that we were just talking about. And our paper is hopefully going to go to publication in January. We're aiming for New England Journal of Medicine, and it should be a really powerful study that will change the whole dynamic of who's a candidate for the duodenal switch and hopefully improve access to it.
Right, we've been around since the 80s, I mean, in the current form doing some of the things we're doing, and it seems like we're still at the beginning. I mean,
right.
We have a lot farther to go. Just a side question, just my benefit, why do you think that this diabetes cure rate is so high? What are the theories on that?
So it's a great question, and
Yeah.
I wish I had the answer because
You're the expert. You should have the answer.
I'm the expert. Yeah. Also, maybe I'd have nicer scrubs. Who knows? You know, I get some black ones like you had.
You got to be a plastic surgeon.
Yeah, I do know. You got to bring it up to the next level. So there are a couple of different theories as to why diabetes goes away after the duodenal switch. And there's a theory called the hindgut theory, which means it's the hormones that are produced from lower down in the intestine that you're bypassing, and so it's affecting things in the pancreas. There's a foregut philosophy or theory that by just bypassing the duodenum itself, you're getting different biochemical makeup and different hormonal changes from that side of the intestine. We don't honestly know what the reasons are. There's so many gut hormones, and your assistant Amy and I were talking earlier about the biome and the microbiome, and we are just beginning to scratch the surface.
Right, in the
on
vagus nerve, we talked about that.
Absolutely.
Yeah.
So we don't really know why the diabetes goes away so profoundly with the duodenal switch. But so far it looks like it's the physical bypass of the duodenum, excluding that from contact with food from your diet, that's making the diabetes go away.
So I'll give you a soft pitch. Just
Let's
throw
hear
a
it.
ball
Let's
at the
hear
air
it.
so you can knock it out. Diabetes medications, how well do those cure diabetes?
Well, they don't cure diabetes at all.
Exactly.
It's a Band-Aid.
Right, so the only true cure, I mean, I don't want to get too far ahead, but is really the surgery in
That's
some
correct.
cases, for some patients.
That's right.
Okay.
It's even for people with lower body mass index. So in the past, most patients that have access to these surgeries are morbidly obese, meaning they have a BMI greater than 40, or they have a BMI greater than 35 with diabetes or one of the other medical problems. But now we're starting to see these patients that have a body mass index of 27 or 29, so they're only 20 pounds overweight, but they have type 2 diabetes, that these surgeries are potential options for them to get rid of their diabetes too.
And a lot of that research comes out of Europe because the United States is a lot more difficult to
That's
do
right.
some of these studies.
South America as well.
Right, so they're doing these duodenal switch procedures on people that are not meeting the criteria in the United States. And what's the criteria in the United States?
Body mass index of 40 or 35 with diabetes.
So they're like a BMI of 30.
Yeah, even in several studies in South America are down to BMI of 27.
Right, and they have diabetes, type 2 diabetes, not type 1.
That's right.
And they're doing these surgeries basically because of their condition, not as much because of the extra weight, which they do have a little bit of extra weight, but
That's
not
correct.
much.
And in Asia also, because the global body mass index is lower in most of Asia than it is in North America, they are lowering the criteria as well. But as you mentioned, the criteria to have an experimental procedure aren't as stringent as they are in the United States.
Let's talk quickly, while everyone's watching, about surgery itself. So when we do surgery, you go into an operating room like this, an operative theater, you have a scrub tech, you have all the people there. What exactly do you do when you do this laparoscopic surgery? That's always a big question because people have ideas in their
Like
head.
what happens?
Yeah.
What happens when we turn the music up?
Yeah.
I understand. So we bring our patients into the room. Because most of my patients are struggling with their weight, we have them on a hover mat. So instead of us trying to lift the person over, we have them on this inflatable mat. We gently bring them over onto the operating room table. We get them in a nice, comfortable position. We get them anesthetized. They're nice, comfortably, completely asleep. We don't do any of this twilight surgery for bariatric surgery. They're completely asleep. And then we prep the abdomen. So they're prepped from about here to here, and then from side to side. And I usually make 4, sometimes 5 very small incisions.
Show me where those are, because
Sure.
that's the question people ask. And,
Yeah.
and in the old days, some of these incisions would be pretty big because you would do hand assisted.
Right, exactly.
So
now
also show the length of these.
Absolutely. So usually I put a 12 millimeter incision right here,
Yep.
and then a 5 millimeter here, 5 millimeter here, 5 millimeter here, and sometimes a 3 millimeter, little teeny tiny
So
one
3
up here.
millimeters here, as a person, as a plastic surgeon, that's something that would be will heal well and it wouldn't be too evident.
That's right.
Yeah, so they could wear something that shows the midriff and
Absolutely.
wouldn't be that visible.
And we try to avoid this incision here if possible, because in some patients the bra line can rub on that incision and can cause it to hypertrophy or get a little bit bigger. So in a lot of cases, I'm just doing 4 incisions, just 1, 2, 3, 4.
And those incisions are placed in the abdomen to help with a lot of things, not just it looks better on your belly when you do this, but it also helps when they stick in the laparoscopic instruments.
That's right.
To help them grab and triangulate the area that they're working on.
And you said the perfect word, because triangulation is, laparoscopy is a lot like playing pool, which is also triangulation.
Yeah.
My father tried to get me to learn geometry by playing pool, but I wasn't pretty good at either one of them. But it's the same idea. When you're doing laparoscopy, if the ball is not lined up, it's not going to go where you want it to go. So that's why we really try to triangulate, because you can sew better if you have a triangle. You have better access to the tissue if you can get to a right angle of it so that you can pick it up and manipulate it.
Yeah. You make the incisions, you inflate with a gas. Which gas is that?
We use carbon dioxide, and
Okay.
we usually inflate it to 15 millimeters of mercury, which is kind of a useless measure to people that are not in the know, but it's just around what your venous blood pressure is. If you go much beyond that, you compress the veins.
Cause blood clots.
Well, you also cause reduction in blood return to the heart.
Yeah.
So we want to keep that pressure pretty low, so right around 15.
So if a patient was going to look at themselves with 15 millimeters of mercury of gas in their belly, would they look pretty distended?
They would look blown up like this. Yeah. And in fact, at the end of every case, I take not a lot of extra time, but I take the extra time to get that extra air out, which helps a lot with discomfort.
Okay.
So the biggest discomfort from any type of laparoscopy is that air being trapped. So not only do I try to squeeze all the air out, but I have the anesthesiologist help expand the lungs to help push some of that extra air out at the end of the procedure, so that patients wake up. And I've had several of them say, "Did you do the surgery?" Which is really exciting, because I also inject a bunch of long-acting local anesthetic in in the areas where most of the nerves are. So
Yeah.
You're familiar with the TAP block.
Oh, tap lock. Yeah, we do that all the time for abdominoplasty.
Exactly.
Tummy tucks, yeah.
So it's the same thing that I do.
So a tap block has a long-acting local, and you inject it into the fascial layers of the abdomen. And what that does is numb up the entire area that you're addressing. Not only that, we use longer-acting locals now that last 2 to 3 days. So you can have almost full anesthesia or full pain control just with that block. It'll be a little bit different because you have the visceral discomfort or the discomfort inside the belly with bariatric surgery, so you're going to have that component.
Yeah.
So you've blown everything up, you have everything in there, and now you're going to do your surgery. You stick a camera in, and the camera is one of the reasons why our generation is so much better than the previous generation, because we grew up in video games. And
well, I wasn't allowed. You know, my dad said absolutely
you snuck
not.
it. You snuck
I
it.
did
Yeah.
sneak it.
Yeah.
I learned all my laparoscopy from my friend's Atari 2600.
Yeah, of course.
Yeah.
I had an Atari also.
Nice. We did not.
Oh, it's embarrassing. We're such nerds. Anyways, so we grew up playing video games, and you're looking at the screen, and you're actually manipulating a joystick, and you're looking at the screen, manipulating, and that's exactly what you're doing in bariatric surgery. The thing with bariatric surgery that you have to get used to, and I'm sure it's still this way, it's been a while, is it's mirrored, meaning that you're looking at a screen and you're doing a movement, but the movement right here goes left on the screen. Is that
Sometimes,
correct? Okay,
yeah.
okay.
And
depending on where the camera is.
Depends on where the camera is.
Yeah.
And sometimes if you're looking backwards with the camera, it can be upside down and backwards,
Yeah.
which requires a lot of spatial orientation.
Yeah.
Now, there are robotic programs that enable the camera to actually digitally subtract and write it for you. So even though you're working upside down and backwards, the camera is actually able to make it so it looks like you're working forward and
that's
have
crazy.
one-to-one movement. It's really neat. But I don't typically use those robotic systems, although I am qualified on them. We usually just use traditional laparoscopy because it's faster, it is less expensive for the patient, and actually the ports are smaller.
Yeah.
So the robotic ports usually have to be between 8 and 12 millimeters. Ours are between 5 and 12 millimeters.
When you
or
do
3 and 12 millimeters.
when you do the sleeve gastrectomy and you make what we talked about, that banana pouch
Yeah.
in the stomach, How do you do that? Is there some device that goes there and clamps it down like a stapler or
Yes,
something like
that's
that?
a great question. So the first thing we put down is we have our anesthesiologist put down a sizing bougie, B-O-U-G-I-E, bougie. It's a metal-lined tube that we put down. It's just a flexible metal-lined tube that we put down into the stomach, and we use that as a guide so we're not making the stomach too small or too big. We then need to take the blood supply off of the stomach that we're removing. If you don't, it'll bleed when you start to cut it. So we take the blood supply off with a special energy device that both stops the bleeding and cuts at the same. So we use a harmonic scalpel sometimes. There's a newer device that I really like that's it's based on something called LigaSure technology. It's very, very fast. It's great for bigger blood vessels. And when I say fast, surgery is not a race. But you have to keep in mind, with morbidly obese patients, the longer they're lying on the operating table, the more damage happens to their muscles and their potassium and all of their lungs, and there's more stress on their heart. So you want to try to get them off the OR table faster. So again, surgery is not a race, but we're trying to find ways to make it a faster experience so they can get up and moving to expand their lungs.
I mean, to interject, that's why you want to go to an expert like you.
Yes.
Because you're proficient and you're not delaying steps.
That's right. So somebody that's doing a 4 or 6 hour gastric bypass, they're going to have a much higher complication rate than somebody that's doing an hour and 20-minute bypass.
And we saw that in the early 2000s when it was just coming out.
Absolutely.
So you deal with the vasculature on the stomach.
Yep.
And how do you get rid of that portion of the stomach in the vertical sleeve?
So it is a modified stapling device. So there are these really neat devices that a couple different companies make. It's pretty standardized.
What's your favorite? Everybody has a favorite.
Am I allowed to say brands on this?
Yeah, you can say brands.
I like this. I like one called Medtronic or Covidien. Medtronic or Covidien. I find it.
The Sunshine Act, you can't get anything.
That's right. That's right. I don't get anything back from them. So, but I happen to like that one. I've used a lot of the different ones out there, but that's my favorite because I find that it has a lower bleeding rate, at least in my hands. Maybe not in their competitors' studies, but I like that one. And what it does is it has 3 rows of staples on each side of a blade that goes to the middle. So
you have a lane here, 3 rows of staples on each side, and then you have normal tissue in the middle that a blade goes through.
That's right.
Okay.
So it staples both sides and then cuts in the middle. And it's great.
Can you do the full length of the stomach, or do you have to do it in sections?
Sections. So I think that the maximum staple load is 60 millimeters, which is 6 centimeters. So I usually use about 5 of those cartridges to get the stomach out.
And all right, so 5 passes. 1, 2, 3, 4, 5. So when it comes to the gastric bypass, where you're taking or cutting small bowel and then reattaching it somewhere else, or the duodenal switch, is it the same idea with the stapling?
Same idea for dividing the bowel, but when I start to connect bowel, then I start to sew. So in a gastric bypass, when I'm connecting the bowel, parts of it I'll staple and parts of it I'll sew.
Like sew?
I'll actually sew it
with
laparoscopically.
Laparoscopically, wow.
Yeah.
Okay.
And then when I do the duodenal switch, there's a lot more sewing. So that's one of the reasons why the duodenal switch is a little bit more of a difficult operation, is you need to hand sew the connection, which...
Right, so hand sewing laparoscopically, from my limited experience when I went through training, it's just very difficult.
Well, it's a practice skill.
It's a practice skill,
yeah. And all through my residency, I had one of these little laparoscopic trainers, and every night I would practice sewing from the left, from the right, with my left hand, all over the abdomen to make sure that I could do it in any angle. And that's the problem, the difficulty with the duodenal switch is you're sewing on the right upper quadrant of a patient's abdomen, even though you're standing on their right side. So it makes it a little bit more difficult because your angle is steeper.
Yeah, you have a steep angle, which is hard. And then you don't have as much movement.
That's right.
With the...
That's right. And I do a 2-layer hand-sewn anastomosis. That means I'm sewing the back wall, then I'm opening the bowel, and then I'm sewing an inner wall in the back, an inner wall in the front, and then
the other side.
And then a front wall in the outside. It's 2 layers.
They also have devices that will do anastomoses for you. Is that correct?
They do. And those devices are good in some places, like up top when you're doing a gastric bypass. But for the duodenal switch, it's still an evolution. And the nice thing about hand sewing it, even though it takes a little bit longer, it takes me about 10 minutes to do that part. there's a much lower stricture rate. So the bowel that you're connecting to each other isn't narrowing and then causing an obstruction.
Because when you use those devices, and just the way they work, they narrow it.
It narrows
right?
it.
And
That's
so when
right.
you can hand sew it, you can keep that open.
You can maintain exactly
Yeah.
how big you want to make it.
And I saw that like the obstructions related to these procedures, and not just gastric bypass, but any kind of general surgery
Sure.
procedure. When the bowel's narrow, they're at higher risk for obstruction in the
That's
future.
right. That's right. And if you make it too tight, not only are they at risk of obstruction, but then you have to do another procedure, go down their mouth with a balloon. They're more prone to developing ulcers and other problems where you've connected those two pieces of bowel. Each time you go back in, it increases their risk of a complication. So you want to try to do it right the first time. So I'll take 10 minutes and I'll sew it by hand.
So let's talk about leaks. That's really the biggest concern after these kind of procedures, besides deep vein thrombosis, which is blood clots in the legs, but we can go through that later. Leaks, the leak rate, what is the leak rate across the country, like all comers, most procedures?
So it's a great question. And first of all, a leak is where you're sewing pieces of intestine or stomach together and the juice from inside leaks to the outside. And that can be a surgical emergency. The leak rate at a national center of excellence, which I am, is 2 to 3%. But we're very fortunate that my leak rate is one of the lowest in the region.
In the country, yeah.
Yeah.
So why is that? Why is your leak rate, which is important to patients, lower, or at least lower than the national average for centers of excellence? I mean, besides just being a good surgeon, is it patient selection? Is it technique? Is it all of the above?
I can tell you the clinical answer, and I can tell you the esoteric
Both.
answer.
I want both.
The clinical answer is, I think that I learned from a really exceptional teacher who taught me to handle tissue in such a way. He said, you be good to tissue, tissue be good to you. And by being gentle with the tissue, not excessively rough and using brute force in the operating room, which many surgeons do use, it really changes how the tissue responds to you manipulating it. That's number one.
So technique is number one.
Technique is absolutely number one.
Okay.
But the other thing is a little bit more esoteric, and that is I'm a man of faith, and I pray for every patient at the scrub sink before I go into the OR. I ask for help with my hands, my heart, my eyes, and my mind, and to work well with the rest of the teammates to take good care of this patient.
Right.
And I say that before every single case. People know not to bother me while I'm scrubbing. A lot of drug reps want to come over to you and talk about their new product, or somebody wants to talk about the game last night. No one talks to me when I'm getting ready when I'm scrubbing for surgery, because I'm zoning in and thinking about that patient, praying for that patient.
Right, and I think that I think that's amazing and great, but I think that even if you're not faith-based, you have to understand that surgeon is mentally preparing and getting ready, and he's focusing in on you. And that is a big part of surgery.
That's right.
To have your game plan, to have your head there, to be a part of the here and now.
Yes.
And you add on the component, I think that faith in medicine is important too. I think that it's additive, and I think it's something we should be open and discuss about.
Absolutely. And the other thing that I do is I don't just think about them before the surgery, but 3 times a day for a week after everybody's surgery, I mention their name, that particular individual's name in my prayers 3 times a day. And that's a critical part of being who I am as a surgeon and as a healthcare practitioner, because in the Talmud it says the best of all physicians is destined for hell. Okay, what does that mean?
It's not good.
It's not good. But the best of all physicians is destined for hell.
Yeah.
What I take from that is the person that thinks that he or she is affecting the change in that individual does not know what's really happening.
Right.
Think about it. You break your arm. You put it in a cast. The doctor put it in a cast. Did the doctor heal your arm?
No, you healed yourself.
Did the cast heal your
Yeah.
arm? No, it healed.
Yeah.
So what are we doing? I'm putting 2 pieces of intestine together. The best I can do is sew it to the best of my ability, but I'm not the one fixing that.
Right.
Our bodies are fixing that, our
Right.
minds, our spirits, our faith, whatever
No,
it is.
I agree.
So it's a combination effort that I take the art and science of medicine and try to combine it for the best outcomes for my
Yeah, so
patients.
it's technique, it's faith, it's humility too, is really what you're saying. Let's talk about it overall. Where are we going with obesity? It's an epidemic in this country and the world. It doesn't seem like we have a lot of answers right now. We're just scratching the surface with bariatric surgery. Where do you think we're going? At the very least, we know we have to increase the usage of bariatric surgery to help people.
Yes, and access to care. There are several organizations with the American Society of Metabolic and Bariatric Surgeons, with the American College of Surgeons, and other entities that are working with our government to try to expand access to bariatric surgery. But again, it's scratching the surface. There are hundreds of millions of people that are struggling with their weight, and only a fraction of the people that actually need bariatric surgery are getting it. We need to try to touch this as a public health issue rather than as a surgical problem. And the question is, when does our government get involved? When do we stand up as physicians and say, we need to change our portion control, we need to reduce our high fructose corn syrup, we need to get rid of our artificial sweeteners and our soda pop?
Right.
Where are we infringing upon capitalism?
And it's a slippery slope.
It is.
Yeah.
It really is. In the short term, if we can just expand access for patients to get dietitian counseling, medical therapy, and surgery if they need it.
Right, and then we're waiting for the future advances. I mean, that's really where we are.
That's right.
Okay, so if you are considering bariatric surgery, Dr. Metz is an expert. He's in Denver, but if you're in this region or the United States, you have, like me, you have international patients fly in to see him. You should check out his website. What's your website?
It's www.bariatricspa.com.
And the www is not necessary anymore.
Not necessary. That's showing my age.
It shows our age.
Yeah.
You should check it out. It's very educational, and you may be on his website right now watching this video, but he's a great resource to look into that.
Thanks very much, Dr. Martin. It was great chatting with you.
Yeah, it's good chatting with you too. Thank you.